Spark encapsulates our passion for exploring the vast unknown of unvoiced thoughts and ideas.
This year, Black infants will be twice as likely to die in the first few weeks after pregnancy than their white infant counterparts. Let me repeat that. This year, Black infants will be twice as likely to die in the first few weeks after pregnancy than their white infant counterparts. Today, my goal is to talk to you about the issue of systemic medical racism and the ways that everybody here today is able to make a difference. My name is Griffin, and I am a senior here at Laguna Blanca School. And 1 year ago today, I began an internship at the Sansom Diabetes Research Institute right here in Santa Barbara, California. I was a clinical research intern, which meant that I was responsible for managing small clinical tasks as part of a national clinical drug trial interested in better understanding diabetic pregnant mothers, also known as patients with gestational diabetes. Now, for those of you who are unaware, diabetes is a metabolic disorder involving inappropriately elevated blood sugar concentrations. And what this means is that the mother really does have a lot of extra glucose in her blood. Now, throughout pregnancy, the mother and child share a bond. Although figuratively, this is true, the mother and child also share a common blood supply, which means that when the mother experiences the sensation of eating, the baby experiences the same increase in energy. And when the mother hydrates, the baby hydrates, which makes sense. However, if the mother becomes diabetic during pregnancy, the infant now has a surplus of energy throughout its fetal development, which means that the tissues that normally use glucose as a fuel for metabolism grow much faster than usual, which can affect a premature delivery of the infant, oftentimes forcing a premature C-section. Now, throughout pregnancy, the mother and child not only share a bond, but also share a common immune system and every other metabolic process involved in maintaining a healthy pregnancy. But after pregnancy, the baby's still not out of the water yet. Shortly after the infant is born, the baby goes into a form of shock where its tissues are used to a lot of glucose, which then gets taken away at the severance of the umbilical cord. And what this means is that the tissues that are used to a lot of glucose no longer have access to it. And you go into a form of shock kind of similar to one you might experience after Halloween, more like if you had a candy-only diet for 9 months and then were abruptly changed to a 1 carrot a day diet. And that wouldn't be fun. Now, these infants born under diabetic conditions are 3 times as likely to die during or after pregnancy than healthy infants, raising the typical infant mortality rate amongst whites from 0.548% to just about 1.7%. Now, it's important to note that this rate is actually fairly low historically, and that if the current trends continue, we should expect infant mortality to approach 0 probably before the end of the century. Although that is ridiculously optimistic, it is still our best outlook, and this occurs for all races, not only whites in the United States. But the point of this talk is not to talk about the significance of modern medicine. For that, I would need a lot more than the 10-minute period I've been allotted here today, and you guys would need a lot of caffeine. But I would like to take a closer look at that infant mortality rate. From the 0.548% white American national average infant mortality rate, the incidence rate for blacks and Hispanics roughly doubles to just about 1.2%. And then applying our 3 times as likely constant for diabetic pregnancies, and our infant mortality jumps to just about 3.2%. This means that for every 100 babies born to diabetic mothers of color, 3.2 will, on average, die, making it unlikely, but still twice as likely as the diabetic mothers for whites. This should not make sense. Why would the same disease, with the same metabolic changes occurring, affect both different races at different rates and at different severities? Here's another example. In 2018, the United States Department of Health and Human Services conducted a study which concluded that Hispanics were 70% more likely to be diagnosed with diabetes than whites, were twice as likely to be hospitalized due to diabetes-related kidney failure, and were 1.3 times as likely to die from diabetes-related complications. Now, when I first came across this trend, I was at the Washington University in St. Louis, where, unbeknownst to me at the time, all of the presenters at a lecture I was at, and all of the physicians, in a broader sense, used racial and ethnic demographics as part of their diagnostics. So I came back to Santa Barbara, to the Sansom Clinic, with a whole host of new questions, and what I found, to me at least, was astonishing. So when screening a potentially diabetic child under the age of 10 years old for diabetes, If the patient satisfies just 2 of the following risk factors, they are considered at exceptionally high risk for developing diabetes and should undergo further screening. If the patient is currently undergoing puberty, if the child is obese, if the child has a first or second degree relative with diabetes, or if the child is one of the 5 following races or ethnicities, the patient or child is considered at exceptionally high risk for developing diabetes and should undergo further screening. But what concerned me was how good enough an indication of disease race and ethnicity was that it was used not only as a diagnostic tool, but actually used in the screening of patients itself. Now, hearing this, one might naturally beg the question, is there a genetic factor that plays a role in the increased prevalence of diseases like diabetes between different ethnic or racial groups? But the short answer is no. Research has shown that time and time again, there is functionally no difference between the metabolic processes that occur both within whites, Hispanics, Latinos, blacks. There is functionally no difference, which means that the reason that these differences are differ in different races is because of systemic medical racism, where socioeconomically less affluent patients have worse access to preventative health care and treatment options than their wealthier counterparts. And because of this, diseases like diabetes, HIV, and asthma are up to 70% more likely to present in Hispanics than whites. This is not only a call for recognition, this is a call to action. We must all actively engage in conversations that lead to policy changes, advocate for proper medical access, and lead to the dismantling of barriers that hinder marginalized communities from receiving equitable healthcare access. And by dismantling these barriers, we can build a future where everyone, regardless of race or ethnicity, is able to lead a healthy and fulfilling life. Thank you.